Distinguished ministers, dear guests, colleagues, I would like to warmly welcome back from lunch and to participate in our case study session, which focuses on transforming diabetes care in Kyrgyzstan. Diabetes is a condition that is generally underdetected, undertreated, undercontrolled, and not only in Kyrgyzstan, but elsewhere in Europe and in the world. In this session, we are going to present a project on improving the quality of care for diabetes that, despite its relatively recent start, already demonstrates successful transformation on how diabetes is diagnosed, how care is delivered, and how to address complications. But this session is not only about diabetes. What unifies this and the other case study sessions that are taking place at the same time is that they all tell the story of the importance of trust in building bridges and enabling the positive change to take place through co-creation. We hope that this session provides you thought-provoking discussions, generalizable lessons, and ideas and inspiration on how to drive the change. As Stacy in the morning said, success generates success, so we hope to generate more success. My name is Marge Reina, and I'm Technical Officer in WHO Regional Office for Europe. And I'm pleased to co-moderate the session with my dear colleague, Jill Farrington, Regional Medical Officer on Cardiovascular Diseases and Diabetes, who has been really instrumental in working together with the country team and supporting the transformation. Jill will introduce the format of today's session, as well as the case study trailer that I hope you may have had a big look already. So, Jill, the floor is yours.
Thank you, Marga. And thank you for coming to this session. There's a lot of competition with the 3 parallel sessions, so we welcome you to this particular session. And as Marga said, we've been working closely with the team from Kyrgyzstan. And we have on the panel people from ministries of health. So we have policymakers and advisors to ministries of health. We have healthcare workers, and we have got diabetes associations and representatives of people with diabetes. And we're going to tell this story of how they have been actively working together during that time. So we're going to start with a 5-minute video, and then I will be talking with the people from Kyrgyzstan, where we will get a bit more insight into how the changes and the transformation and the process has happened. And then we will have a reflective keynote intervention, technical intervention, and then we will have a further panel discussion reflecting on what we've heard and how it is relevant to other countries, other parts of Europe, and other issues around scale-up of projects and initiatives. So I think at this point we can start the video. Thank you.
Люди, которые болеют диабетом, просто они немножко боятся, наверное. Вот есть такие люди старого поколения, наверное, они немножко боятся, наверное.
Ну, с диабетом можно жить, но, знаете, со временем врачи нас научили, что надо бороться с этим, чтобы жить долго и безболезненно. Последние годы наши врачи и медсестры стали очень эффективно бороться с сахарным диабетом.
Биз буга чейин үй бүлөлүк медайымдар бул жугуштуу эмес ооруларды өтө мындай үй бүлөлүк дарыгерлерге жөнөтчүбүз. Бул окуунун алкагында мен азыр бардык 18 жаштан өйдө
In 2022, the Ministry of Health of Kyrgyzstan, supported by WHO Europe and the World Diabetes Foundation, launched a new project to improve the quality of diabetes care in the country.
Вначале, до проекта, знаете, у нас существовала такая проблема, что пациенты, они были предоставлены только врачу-эндокринологу, то есть они не доверяли семейным врачам, семейным медсестрам, поэтому вначале, когда мне рассказали суть проекта, что мы должны делать, да, во время проекта, я была под большим сомнением, а смогу ли я отдать своих пациентов семейным врачам, смогу ли я отдать своих пациентов семейным медсестрам. И благодаря этому проекту, знаете, мои ожидания превзошли, получается, все мои ожидания превзошли, да, желаемого результата. То есть сейчас я полностью уверена и могу спокойно делегировать свою работу семейным врачам и семейным медсестрам.
For this change to succeed, trust had to be at the heart of everyone's efforts.
С врачом я соглашаюсь. Я говорю, да, значит, если у меня сахар увеличится, значит, мне поднять надо дозу инсулина. А если доза инсулина поднята, значит, я себя буду нормально чувствовать. Если мне врач говорит, Мира, иди, надо вот так сделать, я соглашаюсь. Но мы сначала поговорим с ней, как всегда, мы как подруги. Я зайду, поговорю, посидим. Она мне объяснит, для чего, почему, как надо, например.
Конечно, новые. Такого не было у нас, чтобы пациенты были на одной ступеньке с врачами, с медсестрами. Это совершенно новая трансформация в нашем Кыргызстане. Медсестры сейчас совершенно по-другому стали обращать внимание на наших пациентов. У них полностью, я же говорю, трансформировалось полностью лечение и как они ведут прием наших пациентов. Все по-другому.
Трудности преодолевали в стереотипах мышления не только врачей и медсестер, но еще и пациентов, которые привыкли обращаться исключительно к врачам-эндокринологам.
Сейчас в связи с тем, что проходили тренинги, мы обучали в пилотируемых районах врачей. И врачи, которые обучены, они уже не так сильно боятся наших пациентов с сахарным диабетом, они уже не отправляют всех на диагностику. Анекдоты из жизни пациентов, наверное, они будут всегда, потому что у меня есть пациенты, которые о себе хорошо заботятся, они мне регулярно отправляют на WhatsApp уровни своего сахара крови, и я уже, если не получаю эти уровни сахара крови, я начинаю переживать, а что случилось с своим пациентом, хотя, в принципе, они бывают очень достаточно в пределах хороших результатов, целевых значений, и я прям довольна, что таких пациентов становится с каждым годом все больше.
Глюкомированный сахар надо узнать. Мы тоже раз в год мы его сдаем, тоже бесплатно. Поэтому, если люди будут такие любить свое здоровье, тогда они будут жить долго и счастливо будут. Вот это самое главное, чтобы люди пошли к врачу и берегли свое здоровье, понимаете? Надо беречь себя. Вот я вот это хотела сказать всему миру, чтобы люди себя берегли, жили долго, прекрасно.
Pleasure to see your work projected in that way. And there is a longer video with even more people being interviewed that I think has been shared with participants in a Dropbox. So we're now going to talk a little bit more with three of the stars of that video, and I'd like to introduce them in turn. So we have Natalia Dobranina, who is the director of the Center for Endocrinology in Kyrgyzstan. She's also the chief specialist for the Ministry of Health in endocrinology, and she's also the coordinator of this project in Kyrgyzstan. Then we also have Asıl Adamalieva, who is the deputy head of the Regional Center for Family Medicine in Alamedin District, Kyrgyzstan. So that's the area in Chuy Oblast where this demonstration project has taken place. And then we have Chinara Abelsova, who is the founder and chair of the Chuy Diabetes Society and a carer for someone with diabetes. So what I'd like to do is start with Natalia asking you a few questions about some of the things that we've seen. If I reflect on some of the things that we've seen in the policy brief and that we've heard this morning, that in transforming service delivery, we need to work both from the top down and also the bottom up, that we need a kind of combined approach where we're working with the healthcare workers, with the patients, but we're also convincing and working with the policymakers. And you have multiple roles, Natalia. You are working at the top level as an advisor, but you are also a clinician who is impacted by some of the changes that you're trying to bring about. Can you tell us from these different perspectives what's been the process, both in convincing the policymakers and also convincing your colleagues about the need for change and how you've brought about that change? And our colleagues from Kyrgyzstan will speak in Russian, so if you need interpretation in the audience, please, now's the time to use it.
Yes, thank you very much. So this project is not the first one in Kyrgyzstan, but this is one of the most successful projects, and we are aspiring for more results. From the very beginning, nobody believed into the success of this project, and as you have seen in the video, we endocrinologists were in doubt if we could refer our patients with diabetes to family doctors, because our patients were not ready to be referred to the first care doctors. And within these 2 years, when the project was realized, we had a lot of problems, and we are going to have those problems in the future, perhaps. But seeing the results, what we could have, we could achieve in this level, regional level, we are not afraid of referring our patients to the first medical care. And our patients trust family doctors more, and also family nurses, as you could see in the video. We have a big problem. We have lack of endocrinologists, and in some regions we don't have family doctors even. And we have very good help. This is our nurses. And of course, the health ministry is the first one to realize the project. It is now at national level. We reform the medical care, medical health care, and they put more attention to nurses, because nurses are not assistants to doctors, but assistants to patients, and their task is to communicate with patients and to identify the needs of the patients. And our nurses are more confident now, and as a result, I hope the diagnostics of our early stage diagnosis is going to be more successful, because now we have 1% of those cases, but we need to have 6, as in the whole world.
Thank you. I just wait for the translation come through. Were there any challenges, any resistance that you were getting from the healthcare workers that you were trying to convince?
Yes, we had very big resistance on the side of the patients because the patients didn't want to be admitted by their family doctors. And then our patients who belong to a special pediatric society, they showed on their own example how to be at the same level as doctors. So they could say what should be changed and what they need. Because in many cases before, the problem was that we just gave different medicine to these people, and our patients didn't trust nurses or the endocrinologists, and those people lived their own life. But now they have more trust in nurses. They also seek for advice from nurses, and they come and ask for help if they have some kind of questions during the training process. And our nurses and family doctors, as I said, are afraid of diabetes, and they don't refer the patient. They are not afraid of diabetes, and so they started to refer fewer people to us.
Thank you. If I move on to Asıl, Asıl, you are tasked with having to actually bring about the change and implement some of the healthcare delivery changes at the local level, and you're having to also be very close to the healthcare delivery, healthcare workers that you are managing, and having to keep them engaged and motivated. We heard that nobody really likes change because it involves disruption. So how have you managed to go about this, keeping people motivated, keeping people engaged, but at the same time bringing about quite a lot of change in the way the care is delivered over the last 18 months, 2 years?
Yes, hello. Yes, actually, when I saw the data of the project and what we need to do for the first time. And that at first I was taken aback, and then I said, we need to win trust, trust, trust. If a person doesn't believe into the purpose and who manages this person, then it will be too difficult to achieve results. And at first we, of course, looked at the reasons why nurses or doctors, why they don't believe that they can manage. We did monitoring, then analysis of our equipment, why our patients don't want to come to family doctors, and they prefer to go to national medical center or the medical center where endocrinologists work. And after we finished this work, because we have visited different family doctor societies, we have talked to many different families and family doctors and nurses, and then we worked out the directions, and then we devised a plan and how to solve these problems. So first it is not enough knowledge, then lack of attractiveness of this family doctor societies, because sometimes they don't have their in-house laboratory, and also there is no equipment that could diagnose the problem, and also there are no specialist doctors in these family doctor centers. And so we devised the steps. First it was training with all, and then we had examination for those doctors and nurses. Then we also had the timetable for our mobile laboratory. So we used to have patients who came to our center, but now they don't have to go far because they can get the consultation near the place where they live. And on the next stage, we started devising the time frame for our specialists to go to different places to consult patients. And this way, patients started trusting us because they could get to the center, which was not very far from their home. They could get medical examination there, and they didn't have to pay a lot of money to get to the capital family centers in the capital. And our organization and we started working together with patients, and this is something novel to us. Our medical colleagues didn't want that at first. They always said that patients are against us and we don't want to work with them. But later we understood that together, three of us are moving in the right direction. And I always say to my colleagues that I'm always available 24/7, 365, and I'm like the navigator of the traffic. I'm always there to help, and we can always find consensus and what kind of events we need in the future. But I would also like to add that we are just at the beginning of our journey, and there are many things to do, what to overcome. But I hope that if our circles are going to grow, then we will manage. And as far as the motivation of our colleagues is concerned, then we had different meetings, and also when patients thank medical workers for their work, they are quite happy. And we also, our organization is also happy to help financially and using equipment. We also offer transport service. And so in this sense, we are always ready to overcome the obstacles.
Thank you so much. And I like also how you started by describing how you used data and the assessment, and you made a diagnosis of the situation, and then you had a plan. It illustrates very nicely some of the points that, again, we see in the transformation policy brief. But you also picked up a comment we heard earlier, that trust is gained through delivery. So you were showing that this could be delivered, and then the trust was building during that time. Now, you've mentioned that you were working with the patients in that, and I'd like to turn now to Chinara. We again heard this comment this morning. We need to see ourselves as a team. It's not patient or doctor, it's a team. And we're trying to improve that care. And there are different ways that stakeholders can be involved in redesigning care and so on. Could you tell us some of the ways that the Diabetes Society have been involved and patients have been involved in the process over the last 18 months, 2 years?
Thank you very much for the invitation. I want to express my gratitude to our colleagues. We, the Association of Diabetes, we participated in training of nurses, of doctors, in road mapping, in monitoring. We participated in political dialogue, where we said that there are problems. Our society advocated. We addressed the Ministry of Health and talked about our problems. Joe, you know, We had a problem with laser, and we stated the fact, we as a diabetes society, we speak here about trust and transformation, but in our country, we first dealt with transformation and then one trust. When nurses were trained, they learned new things, but when they became more skillful, they already talked in a very skillful way with the patient. So they were kind of a bridge to build up the trust.
So what made you feel involved in the process and being included in the process that has taken place? What were some of the different roles that you had to take? Also, I'm thinking about, I think you'd mentioned around the monitoring of the care that took place.
Yes, we participated in road mapping together with doctors, nurses. Once the patient comes to the outpatient clinic, what happens? Next, all the road mapping. Then we participated in monitoring. That is, with a group of doctors, a monitoring group. We visited several places, several units, to see how the process really takes place, how our patient covers the pathway from the reception desk to the visit to the doctor. So we work together.
Okay, thank you so much. So I'm going to pass to Marga, and then we move to the second part.
So thank you very much for the brilliant speakers, the protagonists of the video, and explaining a little bit of how that transformation took place, and from really working through assessment and carefully planning and understanding the importance of the trust. But I would want to know that the audience also use the opportunity to ask questions from our speakers from Kyrgyzstan. To maybe there are some aspects you want to know more, or also tell a bit of how it resonates with your case, and just to kind of clarify a few aspects. We have a couple of minutes to make sure that your questions regarding the case is answered. But then, because we have also microphones available, but I don't see that that there are any questions from the floor, and it looks like it's rather clear story, and also I was very pleased that you were now through that video introduced to our protagonist Mira, who was nicely introduced already in the opening session. But I would like to now invite Professor João Raposo, who has several hats from Portugal, being clinical director and the Diabetes Association of Portugal, but also not only also throughout Europe being involved in the Diabetes Association. So, and he will provide a bit of reflection on how this Kyrgyzstan case is reflected in the broader, both the diabetes care transformation, but also as a transformation and building trust. So the floor is yours.
Thank you, Marga. So good afternoon. Thank you for the introduction. As you've heard, my name is João Filipe Raposo. I'm coming from Portugal, Lisbon. I'm the medical director of the Portuguese Diabetes Association, which is a patient association. But I'm currently also the president of the Portuguese Society of Diabetology. That's the scientific society, the multidisciplinary scientific society in Portugal. And I'm a professor in the field of public health and non-communicable diseases in one of the medical schools in Lisbon. a part of that, I'm part of the board of the International Diabetes Federation Europe, from the board. And I've been working, and I think that's the technical intervention here is, I've been part, and I'm proud part of this team that has worked with Kyrgyzstan, and I think this is quite a happy moment for us to share this experience. And I think people in Kyrgyzstan have the luck to have such a brilliant team also involved in achieving transformation in their health system. So congratulations. And just to share that from the WHO part, I'm not alone here, so Jill Farrington has introduced herself, but also Elena Tsoi and Tina Latikan, and all the team at the country office from WHO are fundamental in supporting this process that I'm trying now to summarize the key aspects, at least in my perspective. And just to tell you that I think it's not by chance that we are in the black box room, because when we're speaking about process and systems, black box usually means that we know what's coming in, we know what's coming out, and we don't know exactly what happens in between. And sometimes it works when we are trying to do that with mathematical models. We can use the black box strategies. But I think what we can try to demonstrate, it's for health system, it's not good if you are speaking about trust. It's not good to speak about black box. So we should be very transparent what happens in the process, why the inputs produce a certain output, because we want to have a focus on the output. And in this case, we are speaking about diabetes care, the health care. And when we speak about outputs, it's not about just biomedical outputs, but also what we are speaking about trust, quality of life, and other things that move people in the right direction. And so I think that's one of the messages that we want to share with you here. The other concept I think might be useful to introduce here is like diabetes could be used as a stress test to health system. Stress test is something that this name is usually used for bank, financial systems as a stress test they can do, but also for factories, nuclear factories. So it's to test the vulnerability and resilience of individual critical infrastructures and infrastructure systems. And the idea is to have a system, and these tests are designed to protect against all hazards and resilience. So we are speaking about trust and transformation, and I think that the process is fundamental if you want to increase the trust and if you want to be sure that transformation drives in the right direction. And for that, we have a fantastic example, what we have seen so far in Kyrgyzstan. And the challenge for all of you in the room is this can be replicated in your countries. And don't consider that we are just speaking about diabetes, but actually diabetes is just a case study for what we want to show in the transformation and the creation of trust in health systems. So again, why diabetes? And how can we try to rebuild trust and transform health systems? You've heard at the beginning that diabetes is a chronic disease, but it's the main cause of cardiovascular disease, blindness, kidney failure, loss of limbs, loss of life. It affects in the European regions around 60 million people, more or less 10% of the adult population. The prevalence is increasing and still is going to increase in the next years. And this increase in the prevalence of diabetes is related to the increase in overweight and obesity, unhealthy diet, physical inactivity, and of the aging population. But also diabetes is a good model because it's also an example of a complex disease, because it's very heterogeneous in its clinical setting. It needs the interaction between many different healthcare providers and different levels of care. It needs a high involvement of people living with diabetes in their treatment. So we have to increase their capacity to self-manage the condition. And now we are confronted also with the emergence of novel medications and technology, which clearly have an impact on clinical outcomes, including quality of life, but also produce a stress in the sustainability of the health systems. We have on the top right, you've seen the report from the World Health Assembly last year, where it has a message to reduce the burden of NCDs through strengthening prevention and control of diabetes. So again, I think diabetes is a fantastic model to present us as a stress test to the health systems, and we are living with it now. So what happened in Kyrgyzstan? So I think we start from one of the WHO materials, the HEARTS and the team-based care, and we try to follow most of the structure that was presented and with some adaptations. There are 5 implementation steps about engaging the team, determine the team composition, and we have merged those 2, and then to design the workflows to reflect the current versus the new model of care. And the yellow part there, it means that in the document, they didn't analyze the current pathway that was speaking about the future. And we thought it was very important to have the time to see what happened in the current model of care. And then it was quite relevant to increase the communication among the team, practice, and the patients that are just mentioned there in the step 3, in the process of Kyrgyzstan, they were involved in the initial team at step number 1. And then we developed a gradual approach to implement the model and optimize the care model. What was different, as I was telling you, from the beginning, we had the involvement of the policymakers, the health managers, the healthcare providers, but also the people living with diabetes and their association. And that was reflected at national, regional, and local level. So this is also different from many of the country experiences. And that involvement also started from the beginning. And for that, as I told you, we had done a kind of situational analysis. And meaning that it was important to know the existing regulations. And we've heard so far about what happened in the health system organization. Where are the family doctors, the endocrinologists, the nurses, the practicing nurses, the visiting nurses? What are the competency profiles of the healthcare providers? Because actually, imagine that only endocrinologists could register people as having diabetes. That's clearly a hidden message for the population that's saying endocrinologists are the ones that have the knowledge on diabetes. And so even the regulatory aspect can provide a hidden message for the community itself. But also about the access to care. What kind of regulation is this about refilling medication? Who can start new medication? Again, endocrinologists, family doctors. And the financing aspects also conducts the wrong or the right behavior. And then it's important to have data. And Kyrgyzstan was also a fantastic example because it has a good IT system providing information, easy access to information. And so it was possible not only to use paper, but good electronic data from the population and to analyze the reporting structure. And then it was important to conduct this focus group with people living with diabetes. And we have conducted that, and there were several domains that were visible. Information, still there needs to know more about the condition. The implication of the cost of living with diabetes, because it's not just the cost of medication, but the cost of all the recommendations that we provide about healthy diet, about physical activity. That represents a burden, a potential burden to the people living with diabetes and their families. And what about the access? What happens in remote areas without access to endocrinologists, as it was the case? And the trust, because people at the beginning said, well, I trust my endocrinologist because he is the one that knows about diabetes. But also people with diabetes were the ones that had the solution. They provide solution, as was the case of Mira that you've heard, where she started community intervention promoting physical activity. So there's power in the community in people living with diabetes. And when we speak about the patient-centered approach, we really have to be sure what we are meaning, because we might have the patient as the center of our care, and we design the system for patients, or we design the system with the patients, and that's the main difference here. And so we analyze the current pathway, finding duplications, gray areas, indefinition areas, task and definition, multiple contacts that were needed for the patient perspective. So we're not considering the current pathway was not considering what happens in real life of people, and then they were surprised because people were missing appointments because they had the need to go every month to the family doctor to have the refilling, the prescription. And then with all the group, it was possible to define a new pathway with clear task definition, with clear timelines, with the referral criteria, with the communication strategy, to start the process of therapeutic patient education just beyond the diabetes, the traditional diabetes school, but how to empower the nurses and the doctors to have a different perspective on the role of therapeutic patient education. And all this has to be evidence-based, efficiencies-based, and also to limit just the clinical needs contacts and not regulatory contacts that sometimes are needed. So what we have tried to do is to have that chain that we can see on the top slide there, from the knowledge to have a capacity to measure, to register, to analyze, to decide, and to assess. Digitalization, it's another key word in this process, because digitalization can be acted as a supportive tool, and that's what's intended in Kyrgyzstan, but we also have to be sure that digitalization can act as a barrier if it's run in a parallel or independent process, because it cannot take into account what was decided in this group. And so that's a very critical area. And just a word in implementation strategy, because we are not presenting here, and no one was trying to do that, a final process. What we are showing here again is the process, a continuous process, where with the involvement of all the stakeholders as in theory. And we have to be sure that we can link that to quality assurance. Because when we speak about quality, sometimes we are just speaking about regulations again, and we have to all to understand that quality is what drives this process. And so we want to assure that we all provide quality care to people living with diabetes. And with that, we have better health systems. So to conclude, this trust that we are discussing, this trust is building on the earliest as possible people's involvement, well-defined, adopt process. And keyword is also adopt, because if people adopt this as their own process, they would trust the process. And with adequate communication between all the people involved. And remember that we involve from the beginning also the people living with diabetes and their association. So, about trust and transformation in Kyrgyzstan, the challenge and the reflection for most of us, is this process possible for your country? And there are not so many good experiences, not so many examples of this happening in many other countries, including my country, sorry to say that. So, again, I think diabetes, and for most of you probably not coming from the field of diabetes, we are not discussing just diabetes care. We are discussing how diabetes can be a good stress test to the health systems. And this process that was developed to health systems can be applied to most of the other conditions. If something is working properly in the process of diabetes, probably can work also for many other conditions. And so this was the example. And just remember that people don't trust black boxes, so discuss the process. Thank you for your attention.
Thank you, Joao, for providing a bit of reflections and insights into the black box that it demonstrates a bit of the transformation that happened in Kyrgyzstan. And transformations are not easy, as you may have seen, that to make the change happen in Kyrgyzstan, there may so many elements that had to be considered and factored in. But one key point that I would take away from the presentations, the video, and also working with the people to get the case study ready, as well as from your intervention, Joao, is that the main key is to involve the people living with diabetes through all steps of the development and implementation of the change, into the change management. And through all levels, as you also said, it's the national, regional, and local level to ensure that through this you build the trust in the change, and then we are working on the virtuous cycle of trust and transformation. But now going forward with the session, handing back to Jill to introduce the second panel to provide reflections. Thank you.
Thank you. So on this second panel, we now broaden out to look at the experience of other countries and also the broader European experience. So we have with us Breda Rafter, who is the Principal Officer of the Strategic Workforce Planning Unit in the Department of Health of Ireland. We have Judith Bidio, who is the Deputy State Secretary for Professional Healthcare Management, Ministry of Interior in Hungary. And we have Elizabeth Dupont, who is the Regional Manager of the European section of the International Diabetes Federation. And then at the far end, we have Medaskar, who is the Senior Program Manager for Care in Asia and Europe for the World Diabetes Foundation. So I'm going to start first with the experience from our colleagues who are in the countries working within the Ministries of Health or Department of Health. And starting first with Breda. I mean, as we've heard, diabetes can be a stress test, but some of the experience of diabetes are similar to those of other chronic conditions. And some of the experiences in Kyrgyzstan can be similar in countries, like a shortage of healthcare workers, the need to shift care from hospitals into the community, from specialists to primary healthcare, trying to raise the autonomy and ability of nurses and the team approach. So does this resonate with any of the changes that you're undertaking in Ireland? And is there anything that you take or learn from this case study or that you can offer to this case study from the experience in your own country?
Thank you, Jill, and thank you for the opportunity to talk about the work underway in Ireland. So Ireland's health reform programme's Launch Care is focused on delivering increased levels of healthcare in the community. So the focus is on implementation, end-to-end pathways that will care for people at home and over time reduce hospital admissions and referrals when it is appropriate to do so. The focus is on prevention, early intervention, care closer to home. I suppose it's the right care in the right place at the right time. So our general practice chronic disease management programme commenced in 2020 and it has been rolled out on a phased basis under the General Medical Card Scheme. It's in operation nearly 4 years now, so that represents 50% of the population. So the conditions covered under that programme are asthma, type 2 diabetes and COPD, including heart failure. So 94% of the eligible GPs have signed up to this chronic disease management programme, and to date, nearly 400,000 patients have been seen under this programme. It's delivered through collaboration with the general practitioner and the practice nurse. And the programme consists of 2 GP visits annually, each preceded by a visit with the practice nurse. And the preventative programme then consists of 1 GP visit annually and also preceded by a visit with the practice nurse. So the objective of the chronic disease management programme is to enable general practice to manage patients with chronic disease in primary care when it's appropriate to do so. And a report recently published noted that 91% of the eligible patients have availed of this, and it's a real success programme that has been launched and is sort of embedded and was embedded in the system all through COVID, so which was really it's really working well. The other thing is diabetic patients and other people with chronic disease management would have access to community hubs where they would meet community specialist teams. And like say a diabetic patient then would have access to a diabetic nurse, a podiatrist and also a dietitian. So that multidisciplinary approach would be prevalent in the community hubs. So there's a number of initiatives underway, and these are all under our enhanced community care programme. But the real focus of Ireland's reform is bringing the care to the community.
Thank you. So those are some good examples, broader than just the diabetes example, which is great. Were there any particular governance issues that had to be used, or mechanisms? I mean, who's paying for that care, or engaging the GPs and family nurses in those changes, or any regulatory changes that were required?
Well, I suppose there's a cost attaching to it is one thing, because our general practitioners will be private contractors, so they would receive a fee. There's care in the community. The governance structures aren't as clear as they are in the acute hospitals, so there's work needs to be done in that area. And I suppose where there are challenges, if people need to be referred back into the acute system, those referral pathways can be a bit blurred. So, there's work required around some of that stuff. I suppose, too, something that my colleague here from Portugal mentioned is a lot of this stuff has been enabled by technology, so we have to really embrace that. And I suppose people extended scope of practice, like advanced practice for nurses and advanced practice for health and social care professionals. And I suppose what we really need to focus on in that then is making sure that the roles are clearly defined. And then I suppose they have to be, when professions take on new skills, that has to be with the regulators, and that there's the appropriate regulation across all of that. So they're all the factors that need to be considered.
Thank you. So if we pass on then to Judith and the experience in Hungary, have you had any similar initiatives where you've been trying to make shifts in healthcare for chronic diseases, any other shifts of trying to get things from hospitals into the community, and again, any particular health system levers or mechanisms you've had to use to bring that about?
Thank you very much, and thank you for the kind invitation. I'm very pleased to be here. I would like to mention two major things which I could raise, and congratulations for my Kyrgyz colleagues, because I think it's really a marvelous achievement that you could reach on managing the diabetes. In Hungary, we could face all the similar problem as it was raised by all the participants on this panel. But I would focus on two things. One is the competence of the GPs or the family doctors, whether do they have competence, do they feel themselves self-confident to start to treat patients with different chronic diseases. And that's why we initiated an educational program when they have the ability to get a license to treat different therapeutic areas, for example, diabetes and an advanced level hypertension, because hypertension is usually a general GP's task to treat, but for diabetes specialty there is a license exam possibility for this for the GPs, and I think it can be a good start to make them be convinced that they are able to treat this possibility. And the other that has been also raised, I really like it, that's who is the person who take care to the patients on their patient's pathway, and it's a very important thing, and it became more and more important. Diabetes is not just a metabolic syndrome anymore or a metabolic disease anymore, but a much complex, and we should focus on where to treat the exact patient, where to send the patient if it is needed. So, and I think this nursing system, it's the most valuable group of people who can really follow the patients on their patient pathway. There can be a dynamic relationship between the nurse and an everyday live relationship between the nurse and the patient, and it would be extremely useful. Of course, the financiation of this possibility, I think, will be a huge question mark for all policy decision makers in the future, because not just in the diabetic care, but all the other chronic diseases, and especially in oncology treatment, for example, for non-chronic diseases as well, we need to find a solution, to find people who can really take care of the patient on their patient pathway.
Thank you. So there's some similarities in what you've both talked about, I think, and also
exactly
with the Kyrgyzstan, the right care in the right place and the right time by the right person, in a person-centered way, but making sure that the healthcare worker actually feels the confidence and competence and has the competence to do what they're being asked to do. Because if they don't have the confidence, they're not going to be effective or increase quality of care. If I shift now, thank you, to Elizabeth from the International Diabetes Federation. In that role, Elizabeth, you're in contact with diabetes associations all across the WHO European region, almost 60 countries and territories, I think. And you've heard here how the Diabetes Society has taken a role in Kyrgyzstan in this whole pathway of transformation. Can you put this example in context? Is this unusual? What's your experience with the different countries and associations? And do you have any examples of similar cases where the associations have been involved in the co-design and the transformation of care and the monitoring of that change afterwards?
Thank you very much, Jill, and thank you for the invitation. And first of all, I really would like to congratulate Chinara for the amazing work and the association that you've did. Yes, IDF Europe represents 76 diabetes associations. And to be honest, I don't think we have ever heard of a patient association that has been engaged since the beginning in the transformation of healthcare systems. I think some patient associations are very, very strong in some countries, for example, like in the UK, like in Denmark, etc. But in terms of association in the transformation of healthcare system as a whole, right from the beginning, I think this is quite innovative, and I really would like to congratulate you on that. We see a number of associations that are achieving quite a number of amazing progress based on the trust between people living with diabetes and healthcare professionals. For example, recently in Poland, we have seen a very strong interconnection between the medical association and the patient association, and these are really brought forward a number of key changes for people living with diabetes in terms of access of some medicines, in terms of access of some technologies, etc. So we see that the importance of having this patient-centered approach and making sure that the person living with diabetes is engaged in the discussion, in the policy discussion, it definitely brings a lot of value. Unfortunately, we think that it's still often only a tick-the-box exercise, and in some very important discussions, people living with diabetes do not seem to be really considered and are certainly not engaged since the beginning of the policy changes that are under consideration. I have some example, for example, in the EU, where we feel, there is always the need for making sure that the voice of the person living with the condition is heard, but there are so many critical aspects where it's awfully absent. Yeah.
Yeah, thank you. So it's a sobering thought that this is an unusual process that you're actually witnessing here. I mean, it's a great thought for Kyrgyzstan, but it's a bit sad for other countries that too often things can be a tick box exercise rather than genuinely engaging with the stakeholders.
If I may add something, I think
yes.
in some countries there is true engagement, but more on specific topics, not on a larger scale.
Okay, thank you. So then if we then turn to Meda, Meda, in your role, you're working with different projects in different countries in Europe and in Asia, and the World Diabetes Foundation was one of the co-funders in the seed money to kickstart this initiative. So in that, there's an advantage. There's some external funding to support this work, but that can also be a disadvantage because when that funding stops, do things collapse? So have you any comments or advice on shifting projects into more sustainable approaches, moving from a demonstration project to more countrywide change? Any examples or learning from other projects in your portfolio?
Yeah, so thank you so much for inviting me to participate in this very exciting session. I'm very pleased to be here together with a team from Kyrgyzstan and obviously also the WHO Euro office to present the great achievements that's been there so far. I think we have some important learnings from this experience, which can also be useful in other settings. Some of them have already been highlighted, but I think the strong determination to keep the project patient-focused from the beginning and throughout the project cycle is really one of the key successes of this project, from the development during implementation and also, as has been highlighted here, the monitoring. Patients or people with lived experiences has a voice which is important to take into account, and we have a lot to learn from these voices. It takes courage to allow different perspectives, and I think that's also what you say about this being quite unique in the composition here, because it takes courage, because different perspectives, it's not always pleasant to hear, but with this broader perspective and being inclusive in the process has a lot to offer in terms of improving project outcomes. And we have talked obviously a lot about trust during the day and the session so far, but I think also trusting the process to really be committed to the process, and then in the end it pays off, as we are already starting to see now in Kyrgyzstan. Second thing from the project I wanted to highlight is the stakeholder composition. To ensure this broad palette of stakeholders is paramount, and I think that's contributing to the local anchoring and the ownership of the intervention. Patient association, professional societies, Ministry of Health, they offer these different perspectives. And taking the time to sit at the same table creates trust. And the project is a practical example of how participation strengthens quality and the delivery of care. So to get back to your question, I think this ensuring this broad palette of stakeholders and the participation, but also allowing a focus on integrated care and avoiding creating verticals. I think also what Zhao said about diabetes as a stress test of the healthcare system, this could be applied to any disease area, but again, trusting the process. Focus on health system strengthening approaches, which are evidence-based and locally adapted. Then the model has a strong foundation for being scaled up and with the right stakeholders on board to take the leap for scale-up. And I think for us at the World Diabetes Foundation, what we are looking at is, of course, is the commitment from the ministries of health, the government in the countries to take that leap. We are also ready to put the funding in and support that scale up.
Okay, great. Thank you very much. I'll pass over now to Marga for the next session, and thanks for all those great interventions and to put this work into context. Thank you.
Yes, thank you from my side as well. As you have seen that the plenary sessions have been rather short in time. So we have made sure that these case study sessions, we have also time to ask, time for the audience to ask questions or to provide their own reflections, because what we want to have here is a conversation between our Kyrgyzstan team members, our panelists, but also you who are in your countries either managing change or you have similar experiences or challenges, because it was interesting to hear from the international speakers that the challenges are similar in countries, and be it in diabetes care or in any aspects of providing care, as well as managing change. So we have at least one speaker. So do we have microphones? So.
Hello, Bartor Benz from the European Diabetes Forum. A question from the team of the case study. As you were closer, I assume, to the people with diabetes, were you also able to detect people earlier than at specialty care level, if you start from the nurse or the GP level?
Let us put the... Natalia, did you get the question right? Yes, please.
So, you know, if we speak about Kyrgyzstan, then the problem of finding patients is the same as in the rest of the world. Our patients came to us when they see the first symptoms. And now that we have changed the work of family doctors, we expect different, because now the doctors know their patients, and so they can find those patients earlier. And now in Kyrgyzstan we have screening programs, and we use those at the level of first medical care or hospitals. And we also used this before, but we didn't have a global monitoring of patients. And last year we started the general examination when we involved the staff of first medical care units, but also our information system, because we have very well worked communication schemes. Then patients started feeling trust, because everyone was saying that you might have diabetes, please test yourself. And then we organized different campaigns at factories, markets. We had social workers and nurses who spoke about that. And then patients came with the diagnosis of diabetes. And since the project started this year, in other regions of Kyrgyzstan, we had campaigns to find those patients. And the results that we got were taken into account by other regions, and they started using the same methods. And so as we are going to use nurses more, then we are going to have more results, and our nurses are ready to find out those patients. Thank you.
question. Thank you for the question, and thank you, Natalia, for the answer. So we have one question from the floor. Anna.
Thank you. It's a big room. I'll stand up. My name is Anne Johansson. I'm the head of the North Macedonia country office for WHO. And I thank you, first of all, to all the panelists. It's been super interesting. Diabetes is something that is just so important and so difficult. One of the things that we've observed a lot in North Macedonia and probably also elsewhere is that you can implement a project, but the sustainability is very low. And so one of the things, I love the sequence that you had with data analysis, policies, etc. So my question is, where did that sit? Who did this? And who is monitoring on a regular basis? Because right now, in North Macedonia, there's a big challenge with that sort of thing. There's no real capacity in the ministry. So how is that done? And then I had one comment to Professor Zhao about, if you can make diabetes work, it'll work everywhere else. That's what I used to think until I went to Uzbekistan a few years ago with a WHO mission on NCDs and health systems, where the diabetes section worked extremely well, but the cardiology part worked really badly. And so it isn't necessarily the case. But anyway, going back to the question to Kyrgyzstan. Thank you.
Thank you.
So I am the only representative of Ministry of Health, and this is not the first project in Kyrgyzstan concerning diabetes. We also had projects on patient training, and World Diabetes Fund helped us. And you are right, saying that many projects are not very stable and not very sustainable. And we hope that our project that is being executed now is going to be more sustainable, because now it is time for us to have prerequisites for this sustainability, because now we're going to have digital patient card. We also have very good team of professionals, and this project is monitored by Health Ministry. And now this ministry also implemented some indicators according to which regional representatives, so the first care units, are going to be accountable for. And it is not going to stop after the finishing of this project. We hope that this project is going to be implemented in the whole Republic.
Thank you, Natalia. We have one more question. I think this is the last one before we start to close.
Hello. I represent Ministry from Turkmenistan, head of the Prevention and Care Department. I want to thank the team of Kyrgyzstan for a very positive experience fighting diabetes, a positive experience that should be spread around to the parties interested. This is a very good experience. I have a question and comment. We in Turkmenistan, to secure the UHC for the third year, all the patients, not diabetes patients and non-infectious diseases, we provide them with medications free of charge. In 2021-22, we provided $32 million for that. In 23-24, we assigned $58 million American dollars for the medications. And in addition, we have lab companies for 2 years. We assigned $18 million for the work of that lab. What I want to say, diabetes, in principle, is a condition accompanied by several other conditions. Lung diseases, heart, oncology problems. So how do you provide medications to the patients? Does the government assign resources, financial support to the patients? Or do you do it on the basis of the grants? So how do you provide medications to the patients? The first question.
Can we have only one, because we have 1 minute only left and we need to summarize and provide answer as well. Thank you. So can we quickly, yes.
We all know that diabetes is a very expensive condition, and as a matter of fact, and Kyrgyzstan is not able to 100% cover all the expenditures related to diabetes. We cover the insulin therapy completely, 100%. All the patients get it. Our patients have access to the diabetes care on the basis of the basic instruments, and we are moving now to the extending the help. Unfortunately, in case and the glycated hemoglobin is also a part of the free of charge service provided by the insurance. With regard to the treatment of the complications, it is a problem. And unfortunately, we're not able to cover these expenditures. So we are focusing on the primary medical care so that our patients wouldn't have these serious complications up to amputation. But in case they have first symptoms of diabetes, being well educated, trained, they would immediately address the doctors. Of course, we'll try to cover not only the basic services, but also complications. Thanks to the project, we received our first laser. And I hope that our patients will be able to get the laser treatment free of charge very soon.
I had to wait until the translation, and so I think this is an excellent example of 3 levels of stakeholders to really closely working together and really listening, and it's not like ticking the box exercise as was mentioned. Just can I go like final reflection, 1-2 sentences from Joao after hearing also the speakers from our international panels and the questions. So what is your like a takeaway that the audience should summarize and kind of take this with them, after reflecting and seeing? So what would you tell to the people in the audience based on the reflections?
Thank you for the challenge, but message to, it's a continuous process, it's an ongoing process, it's not a perfect process, but involving the patient association, the people living with the conditions, in defining the health system, I think was the main key message, with a good communication process. So just to tell it very shortly, it's not about we have to change because there's a shortage of some professional. We have to change because we can do it better with another setting.
Thank you. I think it's a brilliant segue to the coffee break, and to please do come back to the plenary 2 session where we bring all the case studies together and provide further discussion on the lessons learned and takeaways. So now the coffee break. It's half an hour. And looking forward to hearing them. And huge thanks for the case study speakers, but also all who were supporting the development and putting together the video and behind that, as well as our international panel, Joao and Jill, obviously. Thank you so much.